عبد الهادي.
Yes.
تفضل.
Assalamu alaikum and good afternoon everybody. I'm Abdulhadi Alama and I'll be covering basics of coronary angiography. These are my objectives. We'll talk briefly and give a review of the coronary anatomy. We'll talk about the indications for coronary angiograms, the vascular access, some types of catheters that are used. We'll mention in a little bit of detail about the angiographic views and how to interpret the angiogram. And lastly, we'll mention the complications and pitfalls. So the left and right coronary cusps give rise to their respective coronary arteries. The major epicardial vessels are considered to be the left main and the RCA. The left main divides into the LAD and the LCX. Coronary dominance is based on the vessel that gives the rise to the posterior descending artery, recognized by the presence of septal perforating branches. It arises from the RCA in 80 to 85% of the population, and from the LCX in 10 to 7% of the population. Codominance is found in 10 to 7% of the population, where the posterior interventricular artery, or the PDA, is formed by both the RCA and the LCX. The left main originates from the left coronary cusp and bifurcates to give rise to the LAD and LCX. Long left main is considered when the length is more than 15 millimeters and the short is less than 5 millimeters. Occasionally, a third branch vessel is the ramus intermedius, arises also directly from the left main. Small number of patients has the LCX and the LAD originating directly from the aorta at separate origins. The RCA arises from the right coronary cusp and follows the right atrioventricular groove. Most proximal branch of the RCA is the conus branch, which supplies the right ventricular outflow tract, and the branch that supplies the SA node in 60% of patients. The RCA gives off the posterolateral and posterior descending branches at the crux cordis. Normal caliber of the major coronary arteries. The left main is usually 4.5 millimeters plus minus 0.5 millimeter. LAD 3.7 plus minus 0.4. The LCX, in case it is not the dominant artery, it's 3.5 plus minus 0.5 millimeter. If it was the dominant, it's 4.2 millimeter. RCA, if it was dominant, 3.9 millimeter plus minus 0.6 millimeters, 2.8 if it was not dominant. Indications for coronary angiograms are the acute MI, unstable angina, chronic stable angina uncontrolled by medications, an abnormal stress test, ventricular arrhythmias, left ventricular dysfunction, valvular heart disease, and preoperative coronary assessment for cardiovascular surgery. Regarding the vascular axis, we have a comparison between the femoral and the radial axis. The axis site bleeding is more common in the femoral than the radial. The artery complications in the femoral can have a pseudoaneurysm and the retroperitoneal bleed, especially if we puncture the femoral artery a little bit high. The radial complications are rare, however, when they happen, there are AV fistulas, it's a painful hematomas, irritation, and 3 to 9% of patients loses their pulse. Patient comfort is acceptable in the femoral, however, it's great in the radial, especially that regarding ambulation, the radial can immediately ambulate. The femoral needs to stay in bed rest for 4 to up to 6 hours post-procedure. Femoral artery sometimes requires a closure device. However, the radial simple band is sufficient to stop the bleeding. Procedure time and estimated radiation exposure is perceived shorter in femoral artery. That's because the femoral artery is usually easier to manipulate, so it's operative dependent. The operators usually find the femoral axis much easier to engage and do any intervention that needed. Access to the left internal memory artery is considered easier in the femoral axis. Catheter selection is important and is dependent upon the following: access site, femoral versus radial, and the aortic width. Dilated aortic root can prove difficult and require special kinds of catheter. Coronary ostial locations, high versus low, anterior versus posterior, and the orientation of the coronary ostia, superior or inferior, horizontals, or a shepherd's crook for the RCA. The standard routine catheters for the routine angiography are the Judkins catheters, Judkins right, or the JR, or the Judkins left. And usually size 4 is preferred. Sometimes they use size 3.5. The ostia are engaged in the LAO projection. We're going to talk about the views later. Catheters generally have two curves, the primary distal curve, as you can see in the picture above, and the secondary proximal curve. The distance between the two curves is considered the length of the catheter. There are many types of coronary catheters used for both diagnostic and a whole lot of others for intervention or guiding catheters. The most important are used the JR or the Judkins right 4.0 or 3.5. This is for the right system, and Judkins left for the left system. Sometimes I've seen amplats used. It's beneficial that it can engage either ostia. Angiographic views. We have, this is the angiography machine. This part is called the tube, which is the radiation source. And this is called the image intensifier. Now, when picturing or imagining the views, I like to neglect this and just focus on this, the intensifier, as the camera. And that way I can picture the views and imagine it in my mind. We have two types of setup. We have this monoplane, a single C arm to take the pictures, and the biplane with dual C arms. Now, a biplane system can prove very beneficial, especially in renal impaired patients, because it will it will decrease the amount of contrast used to the half, because we are taking two views simultaneously. However, sometimes it can prove difficult to get the exact angles that we require, right? Because both C arms will collide with each other, and that is the advantage of the monoplane, that it can move freely. So this is our patient on the table. We are looking at him from the ceiling. Just to imagine the views, we have 10 standard views. These are the views, and depending on the location of the image intensifier or the camera, as I like to picture it. The cranial views, RAO is an acronym for right anterior oblique. Just think of it as right. So RAO cranial, AP cranial, LAO cranial, or left anterior oblique cranial. Cranial views are usually nice for visualizing the middle segments and the distal segments. That's generally speaking. There's no specific rule. The caudal views, RAO caudal, AP caudal, LAO caudal, they are usually great for the proximal parts and the left main. And we have the straight views, RAO straight, AP straight, LAO straight, and left lateral. This is the 90-degree parallel to the patient from the left side. So we'll go, and this is an example of a 50-year-old female presented with unstable angina. I've managed to get her full angiogram. So we'll just show some of these views. Identifying the views can, at the beginning, be difficult, especially if you don't have the actual view written. So what I like to do is just look at the ribs. If it is directed to the right side, I know I'm in the right orientation, RAO. And then I move to look for the diaphragm, which I cannot see here. If I cannot see the diaphragm, then I'm in the caudal view. So this is RAO caudal, with the image intensifier or the camera being at this side. We mentioned that the caudal views are usually good for picturing the proximal parts and the left main. You can see here is the left main bifurcating into the LAD and the LCX. As you can see, it's a normal coronary angiogram. This is called the spider view. Again, we'll look at the ribs on the left side, directed to the left. The spine is on the right, so that means I'm in the LAO orientation. I cannot see the diaphragm. That means I'm in the caudal orientation. So LAO caudal is it terms the spider view because of the shape that the LCX takes and the whole vessels. So this is great for visualizing also the left main and the proximal LAD and the proximal LCX. You can see actually the whole LCX in here without any lesion. So again, this is the diaphragm. So I know that now I'm in the cranial view. The ribs are somehow horizontal. It means I'm in the AP view, AP cranial. AP cranial is supposed to be great for the proximal LAD. However, we have this overlap here. Ideally, the radiographer would angulate the intensifier a little bit differently to remove this overlap. However, we can see the whole of the LAD up to all the distal part. We mentioned the cranial is good for the distal. The cranial views in generally are good for the distals. We can see the distal of the LAD and the distal of the LCX. So again, I can see the diaphragm. I know I'm in the cranial orientation. The spine is on the right. So this is LAO cranial. This is good for visualizing the mid and distal LAD and distal LCX, especially in a left dominant system, which is not the case here. So this is the diaphragm. So I'm in a cranial view. Ribs are directed to the right side, RAO cranial. We can see here the proximal part. We cannot see it's all overlapping, so we cannot really judge it, but we can see the mid segments and the distals very nicely. Whenever we can see the sternum, we know that we are in the left lateral view. So this is a 90 degrees, or in this case, 91 degrees on the patient. Also, it's really nice here. You can see the whole of the LAD and the LCX. We move on to the right system. Right system, usually in a normal study, 2 views are enough. They do an AP cranial. This is the diaphragm, so we know we're in the cranial views. The ribs are horizontal. So AP cranial. You can see the all the RCA and its distal parts without any issues, nor lesions. This is the spine is on the right, ribs directed to the left. So this is LAO, although you can see here the diaphragm, it's not as prominent as in the cranial pictures. This is LAO straight. It also gives you a nice view of the whole RCA. So to interpret our images, we need a systemic interpretation of a coronary angiogram would involve evaluation of the extent and severity of coronary calcification just prior to or soon after contrast opacification. So the calcifications are seen without injecting the contrast as little black dots. Lesion quantification in at least 3 views, and we will judge the severity, the calcifications, the presence or absence of ulceration and thrombus, the degree of tortuosity and lesion classification, and reference vessel size. Analysis of the angiogram. This is it's judging the degree of the stenosis. So normal artery or normal vessel is less than 25% stenosis. Non-obstructive lesions or non-obstructive coronary artery disease, when we have less than 70% in all vessels except the left main. And the left main is supposed to less than 50. Anything above this is considered significant lesion, above 70 and above 50 in the left main. Subtotal are 91 to 99%, and coronary total occlusion is when there is 100% stenosis. There are other methods of analyzing the coronary angiogram, because the previous method we mentioned is by visual estimation of the operator and his experience. This is a quantitative coronary analysis, and the radiographer can do this on the computer. It features a single vessels and bifurcation analysis, including calibration, automatic contour detection, and quantification of the severity of the stenosis. Other methods also include the intravascular ultrasound. They send out sound waves into the vessel wall, and that energy is sent back to the catheter to reconstruct an image. You can see this part is the adventitia, the media, and the intima, which is supposed to be a thin layer around the vessel wall. However, you can see here that it is thickened due to mostly plaque, often eccentric or asymmetrical, and this is the lumen that the blood has to flow through. Another method is the optical coherence tomography, or the OCT. It's like the ultrasound, but it uses light waves instead of sound waves to construct the image. Fractional flow reserve. This is a measurement of pressure differences across the coronary artery lesion to determine the likelihood that the patient would benefit from an intervention. So it's a fraction between the two pressures. An FFR of 1 is widely accepted as normal and requires no intervention. FFR lower than 0.75 or 280 is generally considered to be significant and requires intervention. Lesion classifications. Type A lesions is usually minimally complex. Discrete length is less than 10 millimeter, concentric, radially accessible, non-angulated segments, smooth contour, little or no calcification, less than totally occluded, not osteal in location, and no major side branch involvement and absence of thrombus. So this would be an easy intervention for the operator. Type A lesion, minimally complex. Type B lesion is considered to be moderately complex, to be tubular length 10 to 20 millimeter, eccentric, moderate tortuosity of proximal segments, moderately angulated segments, irregular contour, moderate or heavy calcifications, and total occlusions less than 3 months old. Osteal location, bifurcation, lesions, and some thrombus can be present. and type C are the most severe complex and can prove very challenging for the operator. Diffuse lengths more than 2 centimeters, excessive tortuosity of proximal segment, extremely angulated segments, total occlusions more than 3 months old. And this can be judged by the presence or absence of the bridging collaterals. The Medina classifications, this classifies the lesions that are considered a bifurcating lesion, and it follows a simple 3-digit number. The first digit will judge the proximal vessel. Second digit will judge the distal vessel, and the third digit will judge the branch, either by 0 or 1. You can see here some example. Lesion here, that is 1, lesion here, that is 1, lesion here, that is 1, 1, 1, 1. You can see here no lesion on the proximal, 0. Lesion on the distal, 1. No lesion on the branch, 0, 1, 0. And so on. TIMI flow grades. This judges the flow of the contrast media or the blood through, across the lesion. A TIMI 0 flow. There is no contrast that flows beyond the coronary occlusion or the lesion. TIMI 1, there is a faint antegrade coronary flow beyond the occlusion with incomplete filling of the distal coronary bed. That's the most important, incomplete filling of the distal coronary bed. That's considered to be TIMI 1. TIMI 2 flow, it's called delayed. So there is complete filling of the distal coronary bed, however, it's delayed. Antegrade flow with complete filling of the distal territory. TIMI 3 flow is considered the normal flow, which fills the distal coronary bed completely without any delay. Myocardial blush grade. It's an angiographic measure of myocardial perfusion. Unlike the TIMI flow judges the flow across the lesion in the major vessels. This describes the ability of the contrast to enter and exit the microvasculature in the diseased artery. And this would theoretically reflect the tissue level perfusion. A normal artery flow is considered as TIMI 3 flow with myocardial blush grade 3. Myocardial blush grade 0, failure of dye to enter the microvasculature. Grade 1, dye slowly enters but fails to exit the microvasculature, and dye staining is still present on the next injection. 30 seconds between injection, usually. Grade 2, delayed entry and delayed exit of the dye from the microvasculature. Dye is strongly persistent after 3 cardiac cycles. And it does not or only minimally diminish in intensity during the washout. Grade 3 has a normal entry and normal exit of the dye from the microvasculature. Dye is gone or is mildly persistent after 3 cardiac cycles of the washout, and noticeably diminish in intensity during the washout, similar to that in an uninvolved artery. Complications of the coronary angiograms, major complications being MI, strokes, renal failure, aortic or coronary dissection, cardiac rupture, air embolism, arrhythmia, and peripheral vascular damage. Minor complications being hematoma at the puncture site, angina, vasovagal reactions, and allergies to contrast agents and drugs. Pitfalls. If there was a short left main or a double left coronary orifice, it can prove very challenging for the operator. The ostial lesions, sometimes they are missed because the catheter, when engaged, the catheter bypasses this ostia, and sometimes it can be missed. Myocardial bridges or collaterals. Coronary spasm can sometimes occur. Totally occluded arteries or vein grafts and anomalous coronary arteries. And thank you.
يعطيك العافية. Nice presentation ما شاء الله.
Thank you.
Excellent presentation.
Thank you.
شكرا يا عبد الهادي. So any questions or comment from the audience?
I think يعني it would be better if we added the cases يعني and we read the angio. I thought we are gonna put it in this lecture and I don't know whether we will be having more.
I'm sorry, what cases?
I mean abnormalities and to read the images and so on, like this.
I thought it would be
But
better
you
just
came
to...
through the basics and it was really nice, that's why, yeah.
Okay. I thought it would be better just to give, bring the normal coronary, and we saw some lesions when in the classification pictures. I can show it again.
Maybe you can include some cases during the MCQ session at the end of the section.
Yeah, maybe, yeah.
We'll see. So I think we are ahead of the schedule because we have a guest consultant today for the second lecture. So we'll see when she will be available with us so we can start the second lecture. Just give me a few minutes to arrange. So we'll wait for 15 minutes for the second lecture. We will start at 1:50, so we can have the guest consultant with us.
تمام يعطيك العافية لؤي.
Just want to stress on one point for the future presenters. It is very beneficial to have a mentor or consultant to be with us during the presentation. So if you can start early arranging for that, and you can involve your chief resident, or you can call me to arrange. If you cannot find anyone, we can call some of the consultants. Just you need to give me an idea before Thursday. Like on Sunday, if you could not find anyone, you can call me, and then we try to arrange from our side or from the chief resident side. Thank you. So we'll go ahead with start with the second lecture, Basics of Echo, with Dr. Mohammed Babgi. I'm glad that we have Dr. Yusra Turkestani, who's a consultant cardiology and echocardiographer from King Abdullah Medical City. Welcome, Dr. Yusra, and I'm glad to have you with us. I think, Mohammed, you can start your presentation.
Thank you, Dr. Lai. It's a pleasure to be with you guys.
Shukran.
السلام عليكم.
عليكم السلام.
تمام البرزنتيشن واضح؟
نعم.
طيب. Assalamu alaikum everybody. Good afternoon. And I'm glad to present today the principles of echocardiography. And first of all, thanks to Dr. Yusra for her supervision and guidance. Starting with the basic of echocardiography. This is the outlines of my lecture, the little bit about the basic principles. Then we're going to speak about the evaluations, parameters for ventricular function, either systolic or diastolic. And we're going to go through the common valvular heart disease and how we're going to quantify and assess it, ischemic heart disease, other cardiac pathologies, and the role of echo in the assessment of those pathologies. And lastly, we'll touch a little bit about transesophageal echocardiography. As a basic transthoracic echocardiography or even transesophageal echocardiography, we have basic applications. Usually we're speaking about the two-dimensional anatomical imaging and the M-mode as well as the Doppler techniques. We have the 3D application, usually with a TEE, and this usually you're taking a different multiplanes of the 2D images, and you the machine will assemble those images and make it as a 3D images. We're going to speak about these basic applications. For the two-dimensional images, we have what's called an orthogonal planes of the LV. And usually are the orthogonal planes. We are speaking about what's called the long axis or a short axis view, and the last one is the fourth chamber plane. And this fourth chamber plane can be taken either from the apical fourth chamber, or you can take it of the subcostal or the subxiphosternal fourth chamber view. And usually we are obtaining these images from 4 common locations. These locations is the transducer location. Either you put it as in the parasternal position, or the apical position, the subcostal, or the suprasternal. It's obvious in these images the common location or the basic probe location for the echocardiography. The first one in the green, this is the parasternal, from which you can get the long axis plane. And the green line, this is the long axis plane. From that one, you can see the image, the parasternal long axis. It's showing you the part of the RV with the LV, LVOT, the aortic valve, and the mitral valve. And from the same position of the probe and the same direction, speaking about direction from the 9 to 11 o'clock most of the time, if you tilt your probe a little bit toward the right side, you might get the right ventricular inflow view. And if you tilt it a little bit toward the left side, you tilt your hand and you might get the RV outflow, which is speaking the pulmonary artery. The first image on the right of the screen up, which is the when you tilt the probe toward the 1 o'clock, represented by the red line, it will give you the parasternal short axis view. And by simple tilting of the probe, you will get at the short axis at different level from the basal one, which is showing the LV and RV, and the LV will be at the level of the mitral valve leaflet. If you tilt it a little bit down, you'll see the same image as is presented here, which is what's called the papillary muscle or the mid-papillary muscle. and it will show the two heads of the papillary muscle projecting toward each other. And if you tilt it a little bit more down, you will get the apical short axis, the apical segment. The second transducer location is the apical one. It's around the fourth or fifth intercostal space below the nipple. You will get the four-chamber view, and with some maneuvers, you will get from the same position what's called the five-chamber view when you open up the aortic valve. This is what's called to assess the aortic valve and the LVOT. And the last, the third position is the subcostal, and it's presented in the the image in the down to the left. This is another image showing the anatomical location, the same as the previous one. The one image that's not shown in the previous one is the suprasternal, as shown in the down on the right. And this is usually to assess the aortic arch and the proximal descending aorta. And this view is helpful in assessing if there is a coarctation or even in aortic regurg. Severe aortic regurg, this might show what's called a reversal flow in case of severe aortic regurg. This is another view of the different planes, the long axis and the up on the left, right, short axis for chamber. And this is another application, what's called the M mode. We'll speak about it in a bit. The M mode. M mode is actually a one-dimension view. It's called an ice pick, in which you are cutting a certain part of the heart, and you will get the different measures and thickness and dimensions through that segment only. So it is valuable in assessing the chamber's dimension as well as the thickness of the chamber, the thickness of the wall, sorry. This is one of the images of the M mode. You can see it's crossing from the RV to the LV, and it's at the LV level. And usually at this image, it should the cursor should cut the tip of the mitral leaflet to be an ideal image to assess the LV dimensions and thickness of the wall. So if we are going, I don't know if you see the mouse of my screen. So if we are going from up here.
Yes, we can see them.
Okay. So as a basic concept of the echo, the nearest area to the transducer will be the most higher or the upmost part of the view. So this one here is the closest segment of the heart to the transducer. And as we are using a transthoracic echocardiography, the nearest one to the sternum or the thoracic cage is the RV. So this is this one in here, this is the RV, and this one is the interventricular septum. This one is the LV, and this one is the LVOT. These two leaflets opening, this is the part of the mitral leaflet here crossed by the cursor, and this here is the left atrium. And this is the posterior wall of the LV. So the cursor will cut from up to down. So this one is the RV. This is the signal of the RV. This is the RVOT, the space, and this one is the interventricular septum. With this movement and a small white line, these are the leaflet movement represented on the M mode, and this one in here is the posterior wall of the left ventricle, and this one the thick hyperechoic segment. This is the pericardium. So in doing the measurement of the LV diameter, one should not confuse with the posterior mitral leaflet and the posterior wall of the ventricle. And from this view, as we said, we are measuring thickness and dimensions. The thickness, the most important thickness we are measuring, the interventricular septum thickness, as well as the posterior wall thickness. As we know, during systole, a good functioning ventricle should have some sort of muscular thickening during a systole. Lacking this muscular thickening is indicative of either a necrotic diseased muscle or a severely dilated and distended myocardium. Other parameter or dimension measured from this view is the end diastolic diameter as well as the end systolic diameter. As if you can see, usually we should combine the echo study with an ECG. So you can time the different cycle of the different movement of the heart with the heart cycle. So this one here during the systole, and you can see how the posterior and the interventricular septum comes with each other. And this is the during the diastole, how it's separating and getting away from each other. And you can measure these dimensions, assess the fractional shortening, and sometimes you must assess the volume, but we're going to speak about it in a little bit. This is another image explaining at the same concept, but this one from a short axis view. You can see you are cutting from anterior to the posterior segment of the wall. This is a short axis mid-papillary muscle. This is the anterior wall, and this is the posterior wall. And you are cutting from the anterior posterior wall to assess the end diastolic and end systolic dimensions or diameter. This is another M-mode images, and this is a different level. When you want to assess and test the mitral valve leaflet, you cut this one at the level of the mitral valve. So you're getting up a little bit away from the LV, and you are cutting through the mitral valve leaflet. So you can see clearly the different movement of the leaflets. And this is very important. It can give you a clue to the pathology of the mitral valve. Usually the anterior leaflet gives you what's called an M shape, and this is consistent with the movement of the, sorry. This is consistent with the movement of the anterior mitral leaflet, and this one, the posterior mitral leaflet, would give you what's called a W shape. This is the normal movement of opening and closure of a mitral valve. Important numbers about the LV and the different cardiac dimensions and measures. The internal diameter of the end diastole and end systole usually ranging from 2.2 to 4 in the end of the systole and 3.5 to 5.6 at the end of the diastole, with the wall thickness is around the diastole and 0.9 in the systole. The important number, the ejection fraction, is the 50 to 85, and the fractional shortening 30 to 45. This diameter of the left atrium and the aortic root, as everybody knows. And RV ventricular diameter is very important in assessing the RV function as well, which is ranging from 0.7 to 7. This is what I was telling about in the M mode in assessing different valve pathology. Most of the time, nobody gives more attention to the M mode, but actually it can give you a hint about the exact pathology, either with the aortic valve you can see in the right side, or the mitral valve you can see in the left side. I'm not going to go through the details of these things, but this is the normal movement, and this is consistent with the early diastolic opening, and then the atrial kick opening, and it will give you what's called the E and the A movement of the anterior mitral leaflet, and opposite to it, the posterior mitral leaflet. If you're having, for example, a prolapse, you will find a downward movement of the leaflet during the systole. So when you compare it with the ECG, you can notice this normal movement during the diastole, and then in the systole, you can notice both leaflets are benching down, and this can give you a clue that the patient is most likely having a prolapse of both leaflets. The same kind applies for aortic valve, either picast or mechanical or calcific, depending on the thickness and different measures.
Can I interrupt, Dr. Muhammad?
Yes, Dr.
Well, the only thing that this is the fundamentals of echo. This is how the echo started as a single plane, and this is there are a lot of times that when echocardiographer can diagnose stuff just based on the M mode, so they can diagnose the mitral valve prolapse, they can diagnose the aortic regurg, just based on the M mode, which is a single plane, as you mentioned earlier. But we're totally moving away from the single plane imaging. We already have it the 2D imaging, and now 3D imaging, which has give us the full look at the valves, look at the structures. We don't rely on the diameters for now, but it's been there because some of the literatures has the older literature has been basing the LV dilation on the dimension, but the new moving is that we're doing 2D, 2 dimension, 3 dimensions. But I guess for the from the surgical point of view, maybe when you read about the LV dilations, the diameters, it help you before assessing the LVAD. It helps in assessing the mitral valve regurg and when do you think this is an LV dilated or not. But I think this is not the main parameters that we use for now. It's just on older parameters. A lot of study has been based on it, but we're moving away from a single plane imaging to 3D and 4D imaging.
Thank you, Dr. Visram.
So don't worry about all these pictures.
No, yeah.
Nobody will ask you about all these kind of pictures. I think sometimes they put it in the echo exam just to test on the M mode, but don't worry about them. You can see them in 3Ds. We will show it to you in 3Ds and 4Ds.
Thank you, Dr. Visram. So the third application is the Doppler Echo. And in the Doppler Echo, we have three types of Doppler, what's called the pulse wave Doppler. And it is a site-specific. Usually it gives you a measurement at a specific site. So you kind of know exactly that this velocity at this specific site you are putting the cursor on. The disadvantage of this this technique is its a limited ability to assess the maximum velocity, which is due to the aliasing phenomena. The second application types of the Doppler study is the continuous wave Doppler, and this is a most accurate measurement than the flow velocity and the direction. And usually it measures the high velocity jet, and from which we can calculate the pressure gradient, from which we know the simplified Bernoulli equation. The drawback of this technique is its inability to locate the specific site of the velocity, which is an added value of the pulse wave Doppler. So this is the difference of the continuous wave and the continuous wave here in the left side. This is how it's going to be present on the screen of an echo. And this is a pulse wave and the mitral inflow. I give you the mitral inflow Doppler wave with the E and the A. The third application, which is the killer flow Doppler, and it's based on the principle of the velocity that's coming toward the probe will give you the a red color, and the one going away from the probe will give you the blue color, which is abbreviated in a part. And as a principle, a higher velocity either toward or away from the probe will give you a lighter color. This is an explanation. As high as the velocity gets, as the brighter the color will be presented. So these some basics about the principle of the echo. Going to the second part, which is the assessment of the LV function. When speaking about the LV function, we have either to assess the systolic function or the diastolic function. For each one, there are different parameters, and we combine all these parameters to get a more objective values. Starting with the systolic function, we have the LV ejection fraction, the fractional shortening, as well as the regional wall motion. And for the diastolic function, we assess it either with a mitral inflow, or actually with all of these, the mitral inflow, the tissue Doppler, and the pulmonary vein flow. The ejection fraction, most of the time you find an expert echocardiographer give you a qualitative assessment, and most of the time it is actually reliable. But specifically in patients in whom you want to follow up regularly and to see the progression of the or deterioration of their condition, you have to have a quantitative measures. And to have quantitative measures, you do the assessment of ejection fraction. As we said, some might use the M mode by calculating the end diastolic diameter and the end systolic diameter, and then convert it to the with a cubed equation to the volumes. But actually, this is a limited modality, and you cannot base your opinion on the M mode because it's given only one section. You don't know if the patient having a regional wall abnormality can affect the ejection fraction. So most of the echocardiographer will use what's called the Simpsons Method. In Simpsons Method, you will trace the endocardium of the LVOT, and usually it's a pi plane. You take a 4-chamber view and a 2-chamber view, and you do your measurement in this diastole and the systole. So, for example, you get a 2-chamber view, and then you measure the end diastolic endocardium. You trace it, and the machine will slice this LV into different thickness, and will get at each thickness the volume, and then we'll summate it with each other and give you the end volume. And then with the calculation of the end diastolic minus end systolic, and we'll give you the ejection fraction. This is the basic principle of the Simpsons method, and most of the time they use this technique to assess the ejection fraction. The second parameter, as we said, the fractional shortening. From the previous slides, as we saw in the M mode, you can measure the end diastolic diameter and the end systolic diameter. And from a simple equation, as we know, the end diastole minus the end systole, you can get the percentage of change of the internal diameter during the different cardiac cycle and get the fraction. The normal range is 30 to 45. Some might get it in a simple way if you have a symmetrical and there is no wall motion abnormality. If you multiply the fractional shortening by 2, most likely this will be the ejection fraction of that patient. An important part of the assessment of the LV function, systolic function, I mean, is the regional wall motion abnormality. And to assess that, we are dividing the heart into different sections. Usually we have a 16th segment, and some might add the apical cap as the 17th segment. So these segments are divided in different views. The short axis view at the basal level, basal means towards the base, the mitral valve leaflet, and the mid-papillary, as well as the apical one, not shown in here, and the 4-chamber view, the 2-chamber view, and the 3-chamber view. This is another one, gives you the different segments of the heart with represented with colors to show the territorial supply of the coronary artery for each segment, from which you might identify the culprit lesion of that patient. So showing in here, you can see this one is the basal view, showing the anterior segment, the septal, the anteroseptal, or posterior. This is the posterior, this is the posterolateral, and this is the anterolateral. If you go down a little bit, this is the same arrangement. If you go a little bit toward the apical part, it will give you 4 segments rather than 6 segments, with the inferior, anterior, septal, and lateral segment. So these total of 16th segment, I'm sorry, with this one, and then we'll give you the apical cap, the 17th segment. There is another view just to show the same thing. So when assessing the regional wall motion abnormality for each segment, you will assess either this part is normal, we'll give it a score of 1, hypokinetic, akinetic, or dyskinetic, or even a 5, which is aneurysmal or diastolically deformed segment of the cardium. As the myocardium gets worse, the number or the score will be higher. There are some changes, especially with the TEE. They might use the thickness, and the normal one representing more than 30% thickness, and so on. Then at the end, you will submit the score, and you'll get an index, what's called the wall motion score index. Usually, we have a 16 segment. If it's all normal, it will give a 16 over 16, which gives you a 1. So any index more than 1 indicates this patient have a ventricular systolic dysfunction. The important thing between the akinetic and dyskinetic to differentiate in the assessment, dyskinetic is the abnormal outward movement of during the systole and inward movement during the diastole. So it's a paradoxical movement of the ventricle. This is what's called the dyskinesia. And the akinetic, the completely non-moving segment of the heart. So this is about the diastolic function, systolic function of the heart. Going to the diastolic function, as I said, first one will get a mitral valve inflow. In this one, you will get a pulse wave at the mitral valve leaflet tip, and will give you the flow during the diastolic phase of the cardiac cycle. The first one, which is the early filling with the mitral valve opening, will give you should be a higher flow, and then followed by the atrial kick, followed by a pause actually in between, and then the atrial kick at the end of the diastole and before systole. And a change in the ratio between E to A will give you an indication of the diastolic function, either impaired relaxation or restricted filling. Normally, the E should be higher than the A ratio. If the A ratio become higher than the E, that means the heart is struggling with relaxation and it needs more time to open up. And in the LV diastolic dysfunction and higher LV end diastolic pressure, the heart is already full. So once the valve opens up, immediately will close sooner. So the ratio, you will find the E is much, much more higher than the A wave, and this is what's called a restrictive pattern of filling. The third one, as we said, is the tissue Doppler. In tissue Doppler, you will put the cursor on the specific, I'm speaking on the mitral side. You will assess on the lateral tissue Doppler at the mitral annulus and the septal one. This is the septal one. And it is the same, but this one is assessing actually the myocardial movement during the cardiac cycle rather than the flow itself. Because sometimes the mitral inflow will be variable depending on different parameters. The patient, if the patient is having an aortic regurgitation, this will affect the change in the preload, will affect the value of the mitral inflow pulse result. So the tissue Doppler will give you a much more sensitive measures than the mitral inflow. And this is the same concept, but because it's assessing the myocardium itself, and the movement during diastole is not, it's going a little bit away from the probe. That's why the Doppler image will be reflected down rather than up. So this is the E wave, and this is the EA wave, and it's called the E prime and the A prime in the tissue Doppler. So in assessing the diastolic dysfunction, either the patient is having a normal LV function, and this is the latest. They used to use the old classification to class it to class 1, 2, 3, and 4, but this is the latest classification for diastolic dysfunction. An average in normal ejection fraction, you will assess the E to the E prime, which is this one, the velocity of the E value to the E prime, and if it's more than 14, there is one criteria. Then the septal E velocity, and this is the septal E velocity. This is at the septal, the interatrial septum, and then the septal E velocity, you assess if this one is less than 7, this is the second criteria, or the lateral velocity less than 10, and this is the lateral velocity. The third one is tricuspid regurg velocity and the LA volume. I will not go in detail of this, just to know the different parameters, and based on that, you either classify patient on grade 1 or grade 2 or grade 3 diastolic dysfunction. The third parameter that you are going to assess in the diastolic assessment of the LV is the pulmonary vein flow. In this technique, you will put a cursor along the parallel to the pulmonary vein, and you will measure the flow across that part. Normally, there will be 2 positive or 3 positive reflection and 1 deflection, downward deflection. The first one is concomitant. You can follow that with the ECG up above it. So the first one is concomitant with the early systole. When the heart is start to eject, the atria will get relaxed and the flow through the pulmonary vein will be forward. That's why we'll give you the first systolic pulmonary vein forward flow. And then with the right ventricular contraction rising the pulmonary pressure, a much more flow will go through the pulmonary vein. This will give you the second systolic pressure. And then at the diastole, when the systolic phase ends up and the mitral valve opens up, the pressure will decrease magnificently, and the flow will go forward through the pulmonary vein to the LA, and this will give you the third positive reflection. Then at the end of the diastolic phase, with the atrial contraction rising the left atrial pressure, where a pulmonary vein flow will be reversed backward, and this will give you the BVA, or the reflected deflection. Just to know from this one, to assess the diastolic dysfunction, a blunting of normally the systolic flow is higher than the diastolic flow. If the systolic flow became less than the diastolic flow, this is what's called a blunting of the systolic flow. And this is an indicative of either mild, moderate mitral regurgitation, or diastolic dysfunction of the LV, or very high end diastolic pressure of the LV. And with higher disease, this blunting might get worse, and then will give you what's called a flow reversal, and will be deflected downward. This is what's called a systolic flow reversal of the pulmonary vein. The second part is the assessment of the right ventricle, and it's a bit difficult to assess the RV function than the LV function with less parameters, but usually you will assess the wall motion of the RV and the thickness. And usually the size of the RV is less than 2/3 of that of the LV. Some clues that might give the indication is the flattening or D-shaped septum with concomitant with a rising of the right ventricular pressure, or deviation toward the LV side. An important parameter is the right ventricular systolic pressure. And usually, this one you can assess it if the patient is having a tricuspid regurgitation. From that, you will measure the gradient, and then you will calculate, you will measure the velocity, and you will calculate the pressure gradient. And usually some added parameters, the size of the inferior vena cava, a dilated IVC, non-collapsible with respiration. This is an indication of a rise right ventricular pressure, hepatic vein flow reversal as well. So we said so far 3 reversal type. We have the pulmonary vein reversal, and this is with the mitral regurgitation or right LV dysfunction, diastolic dysfunction. We said the hepatic vein reversal, and this is with the RV dysfunction. And we said the aortic arch or the proximal descending aorta reversal flow, and this is with severe aortic regurgitation. And the assessment of the superior vena cava dilated SVC will give you a clue as well on the pressure, higher pressure of the right side. Very important objective value, what's called the TAPSE, or the tricuspid annular plane systolic excursion, which is measuring how much the annulus of the tricuspid valve is moving toward the apical part. And then this you can assess it by the M mode, and you will see how much it's traveled forward toward the apex. Normally, it should be more than 1.7. Any measurement less than 1.7 indicating an RV dysfunction. This is how it looks like to assess it, and this is the M mode. You cross it from the apex until the tricuspid annulus on the lateral side, and you shouldn't cross the interventricular septum, or it will give you not much accurate value. And then you will assess it in the M mode. You assess the height. This is the height of the tricuspid annulus traveling toward the apical part. This is how it looks like a D shape due to increased RV pressure. And you can see in here how the septum is pushed toward the LV side, and it gives you the D-shaped appearance. The second part of the lecture will be about the valvular heart disease. Starting with the first one, and one of the most common pathologies seen is the mitral valve stenosis. As a general rule in any assessment of any valve, the assessment starts with the visual assessment of the valve morphology. For the mitral valve, we have the leaflets, the annulus, and the subvalvular apparatus or the subvalvular structure. Any of these parts with any abnormality can be a cause, or the pathophysiology can be the pathophysiology of the stenosis or regurgitation whatsoever. So you assess the thickness, the calcification, mobility, as well as the vegetation. A normal area is 4 to 6 centimeters. And one of the characteristic feature of aromatic mitral stenosis is one of the common cause or the commonest cause of mitral stenosis is the fish mouth appearance in the short axis view. And this is how it looks like. This is the basal short axis view. And you can see this is the anterior mitral leaflet near to the septum. And this is the posterior mitral leaflet near to the lateral wall of the heart. And this is the mid-papillary muscle. So you can assess the leaflet anatomy and you can assess the papillary anatomy as well. And this is, you can appreciate in here how hyperechoic, calcific, thick leaflet tip and small mitral orifice. This is the fish mouth appearance, and this is the characteristic of rheumatic mitral stenosis. Another characteristic feature, and you can see it in the long axis parasternal view, it's what's called the elbowing of the anterior mitral leaflet. You can appreciate how the anterior mitral leaflet is a little bit fixed in its opening, and the movement will give you the shape of the elbowing, the elbow joint, or what's called the hockey stick appearance. This is another view. This is much more clear for the hockey stick appearance. You can see how restricted opening of this part of the anterior mitral leaflet and the thickening of the tip. And I'm emphasizing on the thickening of the tip of the leaflet, and this is usually how the mitral valve stenosis due to rheumatic occurs, the thickening at the tip of the leaflet. In contrast to the calcification, in which you would start with the annular calcification, and it will involve the mid part of the leaflet of the mitral valve. There's another view of the short axis. We're going to speak about the gradient and the Doppler and how we're going to use it to assess the valve area. So first thing, as we said, assessment by visual assessment, assessing the leaflet thickness, calcification, all of these things. Second, we have to have some quantitative or objective measures to judge either is it mild, moderate, or severe disease. So one of the important measures is the mitral valve area or the orifice area. We have different methods to assess the mitral valve area. We have what's called a planimetry method. For this one, sometimes it is difficult to obtain an accurate view due to either excessive calcification, difficulty with obtaining that view. So not all the time is reliable, but there's one of them. What you do is you go to the short axis view and you go to the end of the systole at the maximum opening, and then you measure the internal orifice of the trachea. You trace it, and the machine will calculate that area. This one method. Another one, and it's commonly used, especially in the aortic valve, what's called a continuity equation. It comes from the basic principle of physics. What comes in equal to that comes out. So if we know that a certain area and the velocity at that area, so we can, the flow at the end of that same tube will be equal to that one. From that, we can calculate the area of the mitral valve, but it's less reliable in the presence of the aortic valve regurgitation or a mitral regurgitation. A third and mostly used in the mitral valve, what's called a pressure half-time. The concept of the pressure half-time is how much is calculating the velocity and the gradient, how much the time is taken from the pressure to be lowered to the half of it, of the pressure. And then you will measure the velocity at that time in milliseconds. You will divide 220 by that velocity, and it will give you the mitral valve area. But this method to assess the mitral valve area have some shortcoming, especially in patients with aortic regurgitation or decreased LV compliance. The reason why is because if the patient is having high LV compliance or decreased LV compliance, I'm sorry, high LV high LV pressure or aortic regurgitation, this will cause a faster or earlier closure of the mitral valve. So the pressure will equalize much earlier than usual. And this will give you a much lower pressure half time, and this will overestimate the mitral valve area. So be careful in assessing the mitral valve area using this method. After assessing the mitral valve area as one objective parameter for mitral stenosis, the pressure gradient measurement. And it is the single most important factor in assessing the severity of mitral stenosis. And it's usually calculated by Bernoulli equation. For any pressure gradient we're going to use in the echo, we will use the simplified Bernoulli equation, which is 4 times velocity squared. And many factors can affect this parameter. Heart rate, loading conditions, stroke volume, all of these can affect these parameters. That's why in assessing the gradient and severity intraoperatively, you might find it a little bit different than the preoperative echo. That due to the anesthetic effect and sedation will lower blood pressure and will give you a different pressure gradient. So how to classify mitral valve disease? We have the mitral valve area and the gradient. And there might be a little bit difference in the latest guideline, AHA, about the severe and very severe. In the latest guideline, they consider a mitral stenosis of mitral valve area of less than 1.5 as a severe, and the one less than 1 is a very severe mitral stenosis. And the gradient of more than 10 as a severe mitral stenosis, with a gradient less than 5 as mild, what's in between as a moderate. Important concept just to know, what's called the Wilkins Score. This is when we want to decide either whether this patient is going to go for a mitral valvoplasty, or he's going to go for a valve replacement or surgery whatsoever. Then you're going to assess this patient using this score. You're going to assess 3 leaflet things and 1 subvalvular parameter. The subvalvular parameter is the subvalvular thickening, and then you're going to assess the leaflet mobility, thickening, and calcification. Based on your assessment, you will give the patient a score, and a score of more than 8, the patient more likely will benefit from the surgery rather than a balloon valvoplasty. This is just some more images of the mitral stenosis echo, and this is, you can see how thickened and thickness is starting from the annular part and involving all the segment of the leaflet and the tip. Even some part of the subvalvular apparatus are thickened, and this could be due to a calcification, heavily calcified and old age patient. This is a 3D image of how it's going to look like. So you can see it's taking one plane and another plane and the short axis plane, and they will summate it together and will give you a 3D image clear enough for you to assess the mitral valve structure and pathology. Then a mitral valve regurgitation. As we said with the previous one, there is general parameter for the mitral valve disease itself, and other things you have to assess it in order to decide either to go to surgery or to wait, whatsoever. And this depends on the types of regurg. Either it is primary or secondary, either it's acute or chronic. So the primary usually due to either myxomatous change in disease of the valve, of the mitral valve itself, rheumatic, calcific, whatsoever. The secondary causes due to either usually it's due to LV remodeling, either due to ischemia or due to cardiomyopathy, which leads to displacement of the papillary muscle and pulling down on the mitral leaflet, or what's called a tethering of the chordae, leading to malcoaptation of the valvular of the leaflet of the mitral valve. Or sometimes with severe LV dilatation will lead to annular dilatation as well, and pulling back the 2 leaflets apart from each other. The second part of is acute or chronic. In case of a chronic disease, it's very important for you to assess the LV end systolic diameter in specific, because following that will decide at the timing of the surgery of that patient. The acute, less likely you'll find the change in the geometry, and the remodeling will not occur as fast as in shots of acute mitral regurgitation to the LV. This is an example of acute mitral regurgitation due to a flail anterior mitral leaflet. You can notice how the anterior leaflet is flying much higher upward than the coaptation segment in comparison to the posterior leaflet. And with the color Doppler, you can notice the jet of regurgitant flow is going and directed eccentrically. And this is one of the characteristics of the jet flow. As we said, visual assessment is the first tool for assessing any valvular disease. When you're assessing the flow, either the flow of the regurgitant jet is going centrally or it's going eccentrically. If it's going eccentric, either due to a restricted leaflet, and it will follow the same direction of the disease leaflet. So if it's a posterior leaflet restricted, so the jet will be posterior direction, or is it due to a prolapse leaflet? If it's due to a prolapse leaflet, then the direction will be opposite to the diseased leaflet. So, for example, this one is anterior leaflet, flail anterior leaflet. So the direction is directed of the jet is going posteriorly. And this is a centrally directed jet, very severe mitral regurgitation. And based on your assessment, you will classify the patient based on the Carpentier classification into 3 types or 4 types, with type 1, 2, and the 3 having an A and B. If the leaflet is normal, this is a type 1, multiple causes, either perforation due to endocarditis, calcification of the annulus, or annular dilatation due to LV dilatation, or a cleft, congenital mitral cleft. Excessive leaflet motion, this is in myxomatous mitral valve or cord rupture or mobility muscle dysfunction, or type 3 is it's due to a restricted leaflet motion. And is it either it's diastolic or systolic, we give it A or B. So summarizing what we said, the assessment is we're having a visual assessment and it's completely qualitative, and we're having what's called a semi-quantitative measures, and this in terms of a vena contracta and the extent or the jet area or the jet extent. The jet area or the jet extent is we're assessing how far the jet is traveling in the left atrium. So if it's reaching up to the upper pulmonary vein, so it's indicating a severe regurgitation. We have the quantitative, and usually this will be measured by the aid of the PISA, or the proximal isovelametric velocity surface area, and this is a certain method in the echo we'll speak about in a little bit. And then we have supportive measures that will indicate the severity of the regurgitation: pulmonary venous flow velocity, the continuous Doppler of the velocity profile, the LA size, the pulmonary artery pressure, and the LA size, all of this. What is vena contracta? A vena contracta is defined as the region of the jet that exits the regurgitant orifice at the narrowest part. So when you're assessing the jet, you will measure the narrowest part, the neck, at which the jet is going out of the orifice. At that part, this is the narrowest area that you're going to measure. And an area of more than 0.7 centimeter or 7 millimeter is considered a severe mitral regurgitation. And it is indirect region of the effective regurgitant orifice area. So this is the LV, this is the LA, and this is the regurgitant flow toward the left atrium. And this is the neck part. You can imagine the regurgitant flow as having a head, a neck, and the body. The head, which is what we will measure as the PISA, the proximal isovelocity parameter, and the neck, which is the vena contracta, and the body is the regurgitant flow. So what is the isovelocity surface area? The same concept of continuity equation. The continuous velocity times cross-sectional area equal the velocity times cross-sectional area of the other part. So if we can measure this surface area, and if we can know the velocity at this area, and we can do a Doppler at the level of the mitral valve, then we have 3 values of that equation, and remaining 1 value, which is the effective regurgitant orifice area. So simply we can get it exactly from this equation. So how we can calculate this surface area or the flow convergence of the regurgitation?
Dr. Mohammed?
Ayo.
I guess it's not me. Your PowerPoint is not moving.
I'm sorry.
Yeah. Okay.
How about everybody else?
Now it's moving.
Okay. So that area, the proximal convergence area, we consider it as a surface area or as a circle or a semicircle. So from the equation of a surface area of a circle, 2 pi radius square multiplied by the velocity, this will give us the first part, and the other part we know the peak mitral valve velocity, and the remaining the effective regurgitant orifice area. This is an example of this. So we are measuring this one. Important things when you're measuring the PISA, to lower this velocity. This is what's called the Nyquist limit. It is the limit at which the aliasing, I will not speak about the basic physics of it, but you lower it in the direction of the regurgitant side. So in mitral regurg, the direction of the regurg is this side, so you lower it down. In the aortic regurg, or if you are using a TE, the direction will be up, so you will lower it up. From that, you will measure the surface area by the same equation. So we have the radius, we measure the diameter, and we get the radius. So 2 pi radius square, and the Nyquist limit, or the velocity, we know it in here, which is 33. So we know 2 parameters. Then we're going to do a continuous wave Doppler across the mitral valve. And we're going to trace that flow of the regurg. This is the flow of regurg away from the prop. That's why it's going down. This is, and then you will calculate the VTI. And you will use that, the maximum velocity, or VTI, whatsoever you would like to use. So you will use the VTI, the maximum velocity in the equation, and you will get the effective regurgitant orifice area, which is 0.3. From that, if you multiply the cross-section area by the VTI, it will give you the regurgitant volume. This is from the same equation of the stroke volume. And the stroke volume equals the cross-section area multiplied by the VTI. So these parameters are more quantitative and more objective parameter. If you are in doubt, usually we use it in mitral valve. If we are in doubt, either is it moderate or severe, either I should operate or not, I will base my opinion and my decision based on these parameters. This is the indication of severity, and effective regurgitant orifice area of more than 0.4 in case of organic disease, or more than 0.2 in functional MR, or a regurgitant volume of more than 60 ml in organic, or 30 ml in MR. This is an indication of severe MR that needs repair. Another value is the regurgitant fraction, which is more than 50%, and other supportive parameters, the pulmonary hypertension, the enlargement of the LV. As we said, we should assess the LV in systolic diameter, because at the end of the systole, the LV is the most smallest diameter. And if it's this in the smallest diameter is more than 40, this indicates a very dilated or a dilated LV that's reaching a point of non-remodeling. After that point, the remodeling or the outcome is worse, and the prognosis is worse. So you have to operate before the patient reaches to this limit. This to explain how visually you might assess based on the regurgitant flow. Is it mild, moderate, or severe? And this is a very qualitative measure. This is a very centrally directed jet. This is an eccentrically directed jet. This is a perforated mitral leaflet, and this is an anterior mitral leaflet. The reason why I said this is an anterior mitral leaflet in the 3D image, because I can see the aorta up in front of me in here. So this is the anterior mitral leaflet, and this is a perforation in the anterior mitral leaflet. And you can notice this is an eccentric jet going through that hole, maybe due to an infective endocarditis. Aortic valve. The same principle as in the mitral valve. Morphological assessment is very important of the leaflet and annulus. One of the commonest congenital anomaly is the bicuspid aortic valve. And when you have a patient with a bicuspid aortic valve, you also need to assess the aortic root and the ascending aorta. A normal aortic valve area is 3 to 4 centimeters. This is the short axis view at the aortic valve level, and this can show the exact anatomy of the aortic valve with a tri-leaflet, and gives you a Mercedes-Benz sign, and the diastole and the systole is to open up completely, so you can assess the opening of the valve as well as the number of the leaflet and the structure of the valve from the short axis view. This is a view of a bicuspid aortic valve, and you can see how it's opening, how there is only one line, vertical line, and it's opening up in the systole and the diastole. So in the short axis view will help you a lot in defining the number of the aortic leaflets. The severity of the stenosis, as we said, the same as the mitral valve, we will use the valvular area. The planimetry method not usually used in the aortic valve, because it's very difficult, actually, most of the time, especially in heavily calcified valve, to get a good image to assess that area. most of the time we use the continuity equation. So you assess the flow through the LVOT, which is equal the flow in the aortic valve. So you know the LVOT area, and you can pulse the LVOT with the Doppler, then you're gonna know the maximum velocity. From that, if you divide it by the VTI of the aortic valve, you can get the aortic valve area. And this is an accurate measurement. It's very important in this method to know the hemodynamic and the LV function of that patient, because sometimes we will come to it. Second is the pressure gradient. It's the same concept. You will use the continuous wave, and you will calculate the maximum velocity, and then you will multiply the 4 by the maximum velocity square, will give you the pressure gradient across that area. This is how to measure the LVOT diameter, and then you're gonna pulse the LVOT to get the VTI at the LVOT. After that, you're gonna do a continuous wave Doppler across the aortic valve to assess the maximum velocity of the aortic valve, and you will add it to the equation, either to the VTI if you use the VTI, and you add it to the equation to get the valve area. These are the parameters and classification of the aortic valve. So aortic valve stenosis is considered severe if you have an aortic valve area of less than 1 or a gradient of more than 40. And the velocity, you can measure the velocity, and here is represented by meter per second. The velocity of more than 4 meters per second indicate a severe MR. Sometimes you have a patient with a very low or area of less than 1 centimeter square, but a pressure gradient of less than 40 or velocity less than 4. And this is a category called a low flow, low gradient aortic stenosis. In such patient, in order to make sure either it is a true severe aortic stenosis or not, you might use a dobutamine inotrope to stimulate the contractility of the ventricle. So if you stimulate the contractility of the ventricle, the flow through the aortic valve will be much more higher, and this will give you, with increasing the flow, it will give you an accurate, much more accurate measure of the gradient. And if you find the patient velocity or pressure gradient increase, this will confirm a severe aortic stenosis, but you have the gradient due to low flow. For aortic regurgitation, understanding the pathology, the same either to be in the leaflet itself due to rheumatic disease, bicuspid aortic valve, sometimes, or most of the time we have combined stenosis and regurgitation. If there is a root disease and the root is dilated, we'll pull away the leaflet, and the ascending aortic dilatation as well, especially in the bicuspid aortic valve. And it is an important clue to differentiate between a rheumatic regurgitation or degenerative aortic regurg. Usually, the degenerative regurg, the calcification is central, and there is no commissural fusion. But most of the time in the mitral or in the rheumatic regurg, there will be a commissural fusion, and the calcification will be diffuse. And the thickening will involve mainly the leaflet-free edges. The same concept of assessing severity of a mitral regurg applies in here. So signs of severe regurgitation, a hollow diastolic flow reversal in this descending aorta. This is what we spoke about when we do the suprasternal assessment. But an important parameter is a large central jet. And this is the measure, you quantify how much the jet is occupying from the LVOT. If it's occupying of the more than 65% of the LVOT, this indicates a severe regurgitation. Another clue that might give you a hint on the severity is the density of the Doppler wave. A much more dense indicates much more flow, because more RBCs are passing through, reflected back, giving you a much denser images. This indicates as a much severe aortic regurgitation. This vena contracta of more than 6. In the mitral regurgitation, we consider more than 7 as a severe mitral regurg. In the aortic valve, more than 6 millimeter vena contracta indicate a severe aortic regurgitation. And the pressure half time. Rapid equalization with lower pressure half time indicates severity of aortic regurgitation. So if you have a very low pressure half time, this indicates a severe regurgitation. And the same concept for the PISA in quantifying the AROA and regurgitant volume. The same thing applying for the severity of the aortic regurgitation. And this is what I was saying about the regurgitant volume from the LVOT. This is the level of the aortic valve in here, and this is the LVOT. And you can notice this is occupying more than 70 or 80% of the LVOT. So this is a severe aortic regurgitation. This is another view of aortic regurg going back. This is a transesophageal echo, a long axis view of transesophageal echo. And this is the dense, the continuous wave Doppler. You can see this is because this is a transthoracic. So the flow of the regurg is going toward the probe. That's why it's reflected and up and the of the baseline, and the stenotic flow is going, the direction, normal direction is going down, it's reflected down of the baseline. The tricuspid valve, usually very rarely to have a tricuspid valve stenosis, but as a measure with the same parameters to assess any valvular stenosis, a gradient of more than 7 is indicative of a severe tricuspid stenosis, or pressure half time of more than 190 milliseconds, because it's taking a long time to open up and the pressure to equalize. So will it increase pressure half time, indicate a severe stenosis. A most common pathology of a tricuspid valve is a regurgitation. And tricuspid regurg, most of the time, usually due to a secondary or a functional regurg, and most of the time it is due to left ventricular or left-sided pathology. In normal people, there will be around 70% of the population they're having a mild tricuspid regurgitation. And as I said, most of the time it's due to either RV dilation or pulmonary hypertension, and most of the time due to the left side pathology. Normal diameter is around 24 to 28. A diameter or annular diameter of more than 40 is indicative of severity, and that need a repair. So these are the parameters to indicate the severity of the tricuspid regurg. A vena contracted, same as the tricuspid valve, of 0.7. AROA of more than 40, and regurgitant volume more than 40 ml. Other supportive measures, the hepatic vein flow. A systolic flow reversal indicates a severe regurg that reflected back on the IVC and reflected back on the hepatic vein flow. Tricuspid valve inflow, E-wave dominance, indicating also a severity of the tricuspid valve. For pulmonary pressure, this is an important measure to assess it in the echo, which is the you can, in order to assess the pulmonary pressure, you need to have a tricuspid valve regurgitation to assess that pressure. So the method to assess that is to apply a Doppler on the tricuspid regurgitation, and you will measure the velocity at that side. You will get the maximum velocity from different views, different plane. You will add it to the equation of the Bernoulli equation, which is 4 times velocity square. You will get the velocity of the RVSP, the right ventricular systolic pressure. In order to get the pulmonary artery pressure, you have to add to it the right atrial pressure, which is most of the time it's around 8 to 10. Intraoperatively, if you are doing a TEE patient having a central line, you know the exact CVP measures, and you're going to add that to the pressure you had, and then you will have the pulmonary artery pressure. This is an image, a 4-chamber view to show the tricuspid valve regurgitation. So quickly about the ischemic heart disease. We said before about the assessing the LV function, the wall motion and thickness. And it is one of the important values of echo in the ischemic heart disease is how to differentiate between a viable myocardium or non-viable myocardium, because some patients might have to go to a hypernation or stunning myocardium. One of the methods is to use a dobutamine stress test or dobutamine stress echo. A hypernating or a viable myocardium, they have what's called okay, they will have 2 response. Okay, with the low dose of dobutamine, there will be a rise or improvement in the contractility of that myocardium. And then with a higher dose, more than 20 of dobutamine, there will be a depression on the myocardial activity. And this is lacking in the non-viable myocardium. So if the myocardium is having these two response, or it has a name, specific name, but whatsoever. So it's responding
biphasic response, doctor.
Exactly, a biphasic response.
Biphasic response. It picks up on low dose. You will see the segments getting better on the low dose, but as you increase the dose, it goes back to being hypokinetic or akinetic. So it's called biphasic response.
Yeah, thank you, Dr. And this is the one way to differentiate between a viable and non-viable. Other things that might help you, we spoke about the wall thickness. So a thickened myocardium, and especially with the systole, if it's getting increase in the thickness, this indicates this myocardium is viable as it's contracting well. A non-viable myocardium will lose the normal thickness. A third important rule of echo in ischemic heart disease is how to diagnose and pick up mechanical complications, especially with extensive MI and patient is having a cardiogenic shock and is not improving. The most common complication, like a free wall rupture or aneurysm, you can see how the apical aneurysmal part in here, and non-moving, bulging outward of the apical part. This is an aneurysmal part, and there will be I think this is a small communication between the lateral side toward the in the free wall. There is a rupture in the free wall. A second mechanical complication, and even though it's not that common, but you see it, we see it. Too many these days, I don't know, with the corona. Ventricular septal rupture. You can appreciate it either to be apical, muscular, or a little bit higher to perimembrane. Most of the time, it's either mid-muscular or apical. You can assess the size of the VSR and the jet direction and the gradient across that defect. A third and very important pathology, which is acute mitral regurgitation due to mitral papillary muscle rupture. And this is most commonly with the posteromedial papillary muscle in posterior or inferior wall MI. Other rules of echo. Of course, echocardiography is very helpful in patients with a prosthetic valve. You assess either post-operatively assess the pressure gradient, you assess the valve area. Important thing to assess, especially after operation, before closing the patient, or before getting out of the OR, is no paravalvular leak. One of the long-term complications, specifically with prosthetic valve, the mechanical stuck valve. Patient non-compliant becomes with cardiogenic shock or pulmonary edema, and they having a prosthetic mechanical stuck valve. Infective endocarditis, a lot of things that come with the prosthetic valve you can assess and evaluate by echo. This is an example of a paravalvular leak. And it's important to understand that in any prosthetic valve, there should be a normal small regurgitant flow, what's called a washing jet. And you have to differentiate between the washing jet and the paravalvular leak. You can appreciate in here these two small washing jets, which is normally considered normal for that patient, but this one eccentric jet, and usually the paravalvular leak comes eccentric and very severe regurgitant flow. This is another one. This is a paravalvular leak, and this is the normal washing jet. And usually you find this washing jet around the hinge point of the valve. This is another view of evidence of a stuck valve, either due to thrombosis or vegetation. Sometimes panas formation will give you a stuck valve as well. Some patients with infective endocarditis or having aneurysm or distillation that formed, and it's helpful. The echo plays an important role in diagnosing, and specifically the transesophageal echo. Endocarditis, of course, and a vegetation most of the time formed in a low pressure area or a low flow area. So in a mitral valve, most of the time you will find the vegetation in the atrial surface, while in the aortic valve, most of the time you will find the vegetation in the ventricular surface. So a vegetation, even I think even for the thrombosis, will come in the same concept will apply for thromboembolic pathologies. So echo will be very helpful in assessing and differentiating these kind of pathology. And one of the important differentiation between the vegetation and non-vegetation, it is this some part, usually location, it's upstream surface of the valvular near the regurgitant jet, while in the non-vegetating mass, usually it's on downstream surface of the valve, and usually the vegetation is mobile and prolapsing structure. These are those were, I'm sorry, those were just more imaging. Okay, more imaging of vegetation, and you can see the aortic valve vegetation just in the down in the ventricular surface. The pericardial disease, most of them are helpful in assessing the pericardial effusion and the cardiac tamponade, most importantly. And these are the important echocardiographic sign of a cardiac tamponade. Most important parameter to assess in patients suspected with cardiac is the RA collapse, as the RA is the lowest pressure part of the chamber. So it will collapse earlier with in the diastole. So the diastolic collapse of the RA or the RV is an indicative of tamponading. A dilated IVC that is not collapsing with respiratory cycle is an indicator of severity. And a Doppler measures across the mitral and tricuspid valve will show it in here. This is the major Doppler, a pulse wave Doppler across the mitral valve. So a variation with respiration, you can see the respiratory cycle in here with inspiration, expiration phase. So if there is a variation during the respiratory cycle between the different E waves, more than 25% across the mitral valve, this is indicative of tamponade. And if it's across the tricuspid valve, if it's more than 40, it is indicative of a tamponade. This is a video, just a small video of one patient we had a couple of months ago. You can notice how the heart is swirling and not that much. Actually, this patient wasn't tamponading. This was a severe cardiac tamponade, but you can see how there is mild diastolic collapse in the RV, especially in the distal part of the RV with a large effusion. And the other parameter, why it's not moving forward? Yeah, this is the this was the pulse wave across the tricuspid valve, and you can see the respiratory variation. But the variation across the tricuspid valve, to say it's tamponade, it should be more than 40% variation. But this was around 25%, so it was a really large and huge effusion, but pericardial effusion, but it was not tamponade. Last things, I will be quick. I'm sorry for taking some long time. The transesophageal echo. The advantages of transesophageal echo, it comes very close to the heart, so the area to penetrate is less. So you can get a much more frequency and get a better imaging quality and resolution. And specifically for the posterior structure, because it's going in the esophagus just close to the posterior structure, meaning the LA, the appendage, the descending aorta, and the pulmonary veins specifically. So in assessing this structure, TE is superior to the transthoracic echocardiography. Of course, it has some contraindication, a patient of esophageal disease with dysphagia, cancer of the esophagus, cervical arthritis or instability, bleeding gastric ulcer or bleeding disease, some might be a relative contraindication, and severe pulmonary disease or hypoxia, especially you're going to give sedation for that patient. Complications that might occur: trauma, hypoxia, arrhythmia, and some sedation-related reaction that might cause complications for the patient. most of the time we use a TEE, and important thing for us as a surgeon, as a perioperative, intraoperative assessment and post-operative assessment with the TEE is essential part of our practice. Mitral valve disease, and in mitral valve disease, the TEE is a very excellent tool in assessing the exact pathology and the anatomy of the mitral valve, but specifically in intraoperative, it's less effective than transthoracic echo in assessing the gradient, the severity of the gradient due to the change in the hemodynamic of the patient. Left atrial appendage to assess if there is a thrombus, and if there is a patient you want to do electrical or mechanical cardioversion, or patient with a stroke, thromboembolic vascular disease, and you want to investigate for any source of showering. Endocarditis, if it's non-conclusive, the transthoracic, you might use the TEE for better imaging and assessing of all structure of the heart. Intracardiac masses, myxomas, thrombus, vegetation, all of these considered intracardiac masses. Aortic disease, especially the arch and the descending thoracic aorta and the ascending aorta as well, because in the views, as we will see, you can assess better the ascending aorta than the transthoracic, and you can see the exact anatomy of that. The sensitivity and specificity for the aortic dissection reaching up to 100%, 95, 98, respectively. Septal defects as well, the intra-atrial septum and the interventricular septum, you can assess it with a TEE better. So standard views of the TEE, we have a 20 standard view of the TEE. You get it from different levels through the esophagus and the stomach. So from the up high in the esophagus, you can get the blue images, this one on the right side of the screen. You can assess the aorta and the pulmonary valve. You have the descending aorta in the short axis and the long axis. You can assess the, if you push it a little bit down and you change the angle with different angle, but up higher in the esophagus, upper esophagus part will give you good images to assess the ascending and descending thoracic aorta. If you push it a little bit down to the mid-esophagus, you can assess the short axis view, what's called the mid-esophageal short axis view. It's around a 30 to 50 degree or 60 degree angle. And you can see the trileaflet. You can assess the interatrial septum and the LALV, RA, and the pulmonary valve. If you manipulate it, you might see pulmonary valve as well as that view. If you move the angle a little bit toward 120, 130, you can get the long axis and you assess the ascending aorta as well. With some manipulation, you can get the in the direction and angle of between 90 to 110. You can get what's called a bicaval view, this one in here. And this is very important in assessing the interatrial septum. You can see the IVC down there. The left atrium as the closest part of the heart to the probe, so will be upmost in the screen. And I don't know where it is. Yeah, this is the IVC will be down, and you can notice the.
معلش حبيبي عشان المحاضرة ما جيت ساعدتك.
خلصنا. This is the last one. Thank you for bearing me. Any question?
يعطيك العافية يا محمد. Thank you for this thorough review of echo.
I would thank you, Dr. Muhammad, for all this very, very, very comprehensive talk about echo. It takes weeks to talk about echo, but he summarized it very well, and he did a great job. So proud of you, Dr. Muhammad.
Thank you, Doctor. Really amazing. Thank you.
شكرا دكتورة يسرا. الله يعطيك العافية. And sorry for the long lecture. I apologize, but this is the best I could to summarize the topic.
No, we enjoyed it.
So any question for Dr. Muhammad or Dr. Yusra? So maybe I can start with a question for Dr. Yusra. Where do you stand in regards for doing a transesophageal echo for patient going for coronary artery bypass grafting without any valve or valvular replacements? So there is a controversy with the surgeons and the echocardiographer. So do you support this attitude?
Well, I don't think any, I don't see any reason to do the TEE, just a regular TEE before every bypass, unless there is a question from the surgeon. Like if the surgeon wants to assess the MR before going to bypass, although the MR, as Dr. Muhammad mentioned, usually it's better assessed when the patient is awake, because usually it's underestimated when you sedate the patient. But to do regular TEE on all the patients going for bypass, I think it's not, I don't see any benefit of it unless you have specific questions. And usually it's done intraoperatively as a part, like I think routinely as intraoperatively, but not preoperatively.
That's what I meant in intraoperative TE before the cabbage.
Before the cabbage, I think in our centers it's mainly done by the by anesthetist, by cardiac anesthesia. Just doing it as a standard. Maybe they'd like to do it as a part of the training. They do it as a standard just before and after as a documentation. It varies from center to center, I think. And all depends about your resources, if you have a anesthetist available there. But to bring an echocardiographer to do a intraoperative TEE just as a standard without any question, I think we don't do it in our center.
Okay, thank you.
You're welcome.
So any other question or comment? Okay, thank you everyone for attending, and I would like to thank Dr. Yusra for sparing this